Well, here we are back with chapter 28, and this is the fourth and final part of this chapter over toxicology. And in this section, we're going to pick up right where we left off, as usual, and we're going to talk about one more toxic chemical that's in the mix of them before we get into discussing some medications that are commonly given for as antidepressants and antipsychotic kind of medications, and then we'll round it off with a brief discussion about some food poisonings. So let's go ahead and get started. And we'll start off by talking about hydrogen sulfide, which is a highly toxic, colorless gas, but it has a very distinct rotten egg smell, so it's unmistakable when you come across it. Poisonings usually happen through inhalation with this particular one, and it affects all organs in the body, but the lungs and central nervous system seem to be hit the hardest when it comes to hydrogen sulfide. Now, symptoms that we often see with hydrogen sulfide exposure, if it's a low level symptom, or if it's a low level exposure, the symptoms we're going to see is like irritated eyes, nose and throat, maybe a headache, a little bit of bronchitis. Of course, bronchitis, or anytime there's lung involvement, if there's a pre-existing condition, there, those symptoms might, appear to be a little worse. High concentration exposures, though, is we're going to see things like nausea, vomiting, confusion, difficulty breathing, loss of consciousness, that kind of stuff. And if it's really high, we're going to see more serious symptoms like seizures, shock, coma, and maybe even cardiopulmonary arrest. So hydrogen sulfide is a very dangerous substance, but it's all concentration dependent. The higher the concentration, the bigger the problems we're going to have. There's no specific antidote for it, so it's going to have to run its course. But we want to make sure that the first thing that we do is get the patient out of the area that's exposing them to hydrogen sulfide. More than likely, that's going to be done by, our friends in the fire department, with the hazmat team and that kind of stuff. They're going to get them out and get them decontaminated before they get to us. The treatment's going to mainly focus on supportive care, paying close attention to watching their respiratory and cardiac functions and intervening in those areas as needed. All right, so let's talk a little bit about some antidepressants. The first one we're going to look at is tricyclic antidepressants. These are kind of fallen out of favor, but they were the go-to medication for many, many years for treating depression. Psychiatric medications are essentially designed to help address issues related to mood, thought processes, orientation, or perception. The National Poison Data System reported that over 137,000 exposures to antidepressants in 2019, and this is a negative number. 137,000 exposures, meaning there was incidents involving these. Ingestion of these medications may be intentional, and it sometimes involves other medications or other drugs being mixed in with it. Remember, typically these patients are taking an antidepressant, because of a depressive issue, and they may use the tricyclic antidepressant as a means to end their lives. So, tricyclic antidepressants were once the main prescription or the go-to prescription for depression. They were also being used in treating insomnia, some eating disorders, and even some personality disorders. The most common of these are, amitriptyline, nortriptyline, those kinds of drugs are kind of a couple of the most common tricyclics that are out there, but there's a few others. These drugs are quickly absorbed after ingestion and easily cross the blood-brain barrier, and that's why they're so effective. They work by inhibiting the reuptake of norepinephrine and serotonin in the brain. Keeping those two key substances present in the brain actually increases, the feeling of well-being, decreases the depressive feeling. So this works by keeping more norepinephrine and serotonin in the brain. And it works in a very particular way. It's going to work differently than some of the others we're going to talk about here in a minute. Overdose can lead to a combination of sympathetic effects and serotonin symptoms, serotonologic symptoms, which we'll talk a little bit more about. TCA may also block the muscarinic receptors, and histamine receptors that may contribute to additional symptoms. So TCA is going to do some things, that some of the others don't do. Some of the side effects were kind of become problematic with tricyclics, which is why it led to the development of some newer, more modern versions. But with these, when we're assessing the patient, we may notice that they're tachycardic, tachypneic, maybe even hypotensive and hyperthermic. The anti-muscarinic properties of TCA may result in signs and symptoms resembling an anticholinergic toxidrome, meaning hyperthermia, dilated pupils, dry skin and mucous membranes, reddened skin, and signs of agitation or delirium, because this anti-muscarinic property is going to give us more of a sympathetic nervous system response, very similar to someone that's been given a large dose of atropine or something like that. Those are the kind of symptoms that we're going to see with these patients. We also will see some changes on the EKG, and these are what's among the most troubling things and the most concerning things that we see with tricyclids. We'll see this prolonged PR interval, maybe tachycardia or a widening QRS complex. They may even have this terminal R wave that is greater than 3 millimeters in AVR. So we look at the AVR and we'll see this R wave that's longer than it should be. Prolonged QT intervals. Of course, these EKG changes are indicative of the significant cardiac effects that TCA toxicity has. The widening QRS complex and the presence of R-terminal waves in AVR are particularly concerning. So when we see these, it's very, very troubling. So 12-lead EKGs are essential with these patients. As these symptoms or these findings are associated with an increased risk of arrhythmias and may indicate severe toxicity. So they'll give us an indication or a window to how much of this TCA that they've actually absorbed. These symptoms are altered mental status, delirium, and seizures can occur due to the CNS depressant effects of TCA, and they suggest the severity of the toxicity. A patient exhibiting severe signs and symptoms within 6 hours of ingestion should be considered in critical condition and require immediate medical attention. Tricyclid antidepressant overdoses many times are fatal, so it's not uncommon for the patient not to make it with these, so they can be a very serious situation. Of course, ensure that you got a good airway, that it's clear, and intubate the patient as needed. Administer oxygen to maintain those O2 sats above 94, and be sure to get an IV for fluid management and medications as needed. As I've already mentioned, continuous monitoring for arrhythmias and cardiac changes is essential because it'll give you an idea of the amount of TCA that's been absorbed. Administer within 1 hour of ingestion activated charcoal if your protocols will allow that. Sodium bicarbonate may be helpful as well, but you're going to need to consult medical control for potential use to correct any acidosis and maybe even help to prevent some arrhythmias. Fluid challenge, if that's necessary, administer 20 mils per kilogram of crystalloids for hypotension, and you may even want to consider vasopressors if that's really not working and if it's needed. So assess the blood glucose levels, as hypoglycemia can occur with these patients, and you'll need to correct that if it is present. Be prepared for agitation and violent behavior and manage that accordingly, just like you would any other behavioral patient. Treat seizures promptly with benzodiazepines, and of course make sure that you transport the patient to an appropriate medical facility for further care. It may require a little more specialized care than some of our smaller, more rural hospitals can handle. So if the patient is stable enough, you may want to consider transporting them to that next level destination. All right, so MAOIs, monoamine oxidase inhibitors. MAOIs are used to treat atypical depression. They increase the levels of some key neurotransmitters, norepinephrine, serotonin, and dopamine. Of course, you'll kind of notice a reoccurring theme with these antidepressants. They work to keep they either increase the levels of these neurotransmitters or they work to keep these neurotransmitters kind of in play. They keep them from being reuptaken. We'll talk about that in a minute. So an MAOI inhibits monoamine oxidase. It's the enzyme that normally breaks down these neurotransmitters. So we're going to inhibit the MAOI, the monoamine oxidase, and therefore keep more norepinephrine, serotonin, and dopamine available in the brain. And this is going to help to kind of stave off those depressive feelings. At toxic levels, MAOIs can actually block the MAO for prolonged periods of time, and depending on the specific medication. So at toxic levels, as you can imagine, it can become more and more problematic, and our symptoms are going to be kind of based on that. Symptoms are going to appear 6 to 12 hours after an ingestion. Cardiovascular effects of MAOI toxicity include hypertension, tachycardia, palpitation, chest pains, diaphoresis, and even atrial dysrhythmias are more common with this one. Effects of severe toxicity may include marked hyperthermia, muscle rigidity, respiratory failure, delirium, and even seizures. Once signs and symptoms appear, be ready to manage some life-threatening events that's going to be coming your way or coming their way. So once we start to see these severe toxic effects, things start to go downhill relatively quickly, and we're going to see a serious event. Make sure you get and maintain a really good and secure airway. Administer oxygen. You may need to RSI this patient, so consider a non-depolarizing paralytic like rock instead of some of the others. Rock would be preferred with these. Establish large bore IV access. Continuously monitor the EKG. Watch for those atrial rhythms to show up. And of course, consult with medical control for further guidance, and they may even give you an indication of what facility to take them to. Treat hypotension with sequential fluid boluses of normal saline. If a seizure occurs, of course, you're going to treat that as normal with some benzodiazepines. And if the patient is hyperthermic, consider administering midazolam to help with that as well, because it'll kind of help with that, with their fevers. Okay, so a different one. This one is, whereas an MAOI is non-selective, this one is a selective serotonin reuptake inhibitor. So when we're thinking about these, we're thinking of tricyclids, we're thinking of MAOIs, and then selective serotonin reuptake inhibitors, SSRIs. We're kind of thinking in terms of, the worst to the least. So SSRIs are not quite as bad as MAOIs, and MAOIs are not quite as bad, as tricyclids. SSRIs are prescribed a lot. They have a much larger therapeutic window, so they've got a lot more. They're a lot more forgiving. So they enhance the serotogenic neurotransmission and inhibit serotonin breakdown. So they keep more serotonin in the brain and not serotonin, epinephrine, and dopamine. It's selective to serotonin. They're safer than tricyclids with fewer cardiac and anticholinergic effects. And of course, there's some common ones out there that everybody's probably heard of, such as Prozac, Paxil, and Zoloft. Those are some of the more common ones. And of course, knowing their generic names as they're listed here is going to be helpful as well. But these are some of the more common ones out there. There's more than these out there. This is just a handful of them that are a little more common. So when we're assessing these patients, be aware that if they've taken this medication or taken this drug with alcohol, we may have things like tachycardia, a little bit of hypotension, and some lethargy present. It's recommended not to take these with alcohol. We might also see some other symptoms of like nausea, vomiting, and tremors. Some less common symptoms would be dilated pupils, agitation, hypertension, seizures, hallucinations, and even dysrhythmias. Those are less common, but they are possible. An overdose without the involvement of other drugs or alcohol typically results in some limited toxic effects. So our management's going to follow a general approach, such as establishing and maintaining a good airway, administering oxygen to keep them O2 sats above 94, and of course establishing an IV. And then we're going to keep an eye on the EKG. We'll do a continuous EKG monitoring on all these patients as well. Control hypothermia using cooling measures. And of course, administer a crystalloid IV challenge, 20 mils per kilogram for hypotension. And you might even need to consider a vasopressor if your fluid challenges aren't working and that hypotension persists. Treat seizure activity as with others with benzodiazepines according to your protocols, and then transport the patient to an appropriate facility so they can get further treatment. So, an idiosyncratic complication that may occasionally arise with antidepressant therapy is something called serotonin syndrome. It can occur with any combination of drugs that enhance the central serotonin neurotransmission. So, what we're talking about is having too much serotonin. So it could be caused by multi-drugs, or it could be caused by too much of any one of the SSRIs. Drugs that can cause this are MAOIs, SSRIs, SNRIs, TCAs, illicit drugs, opioids. So a lot of these can actually cause this, not just these antidepressant drugs. And of course, even herbal supplements can cause it as well, and even some over-the-counter medications. So this serotonin syndrome is something that we sometimes can see, and while it can be tied to antidepressants, as you see on this slide, can also have other causes as well, and not just that. The onset of serotonin syndrome usually happens within 6 hours of ingestion, and signs and symptoms are going to include at least 3 of the following. So to be classified as true serotonin syndrome, it needs to have 3 of the following of any one of these. So of course, agitation, that's an easy one. Call an ambulance on somebody and they are agitated. So ataxia, diaphoresis, diarrhea, hyperflexia, mental status changes, shivering, tremors, hyperthermia, tachycardia. Of course, any one of those, if you've got 3 of those, then we should have a high index of suspicion that there may be serotonin syndrome going on, especially if they're taking, antidepressants, any one of these antidepressants that we've just talked about, or, some of the other, if they're, opioids and that kind of stuff, if they have an addiction. So pre-hospital treatment is supportive, and consider cooling measures if the patient has hyperthermia. And so we can kind of get their temperatures down. But this serotonin syndrome sometimes does happen with patients that one physician has prescribed this medication for this particular thing, and it may not be an antidepressant, and maybe another doctor has prescribed an antidepressant, and they don't realize, one doesn't know what the other's doing. Maybe this patient didn't report their medications correctly, and now we've mixed these 2 medications, and we wind up with that results in serotonin syndrome, which can be quite troubling when a patient deals with that. So lithium is a commonly used mood stabilizer. It is the main treatment for persons experiencing bipolar disorder. Lithium helps dampen mood swings rather than altering normal mood, so they kind of try to even things out, mellow things down. Lithium is almost completely absorbed in the gastrointestinal tract, typically within 8 hours of ingestion. Approximately 1/3 of the dose remains active for about 2 weeks. So there is a high risk of toxic levels and overdose with lithium. So it needs to be carefully and tightly managed. And it takes a while for that to kind of build up. As you can see, as somebody starts taking it, maybe 2 weeks before the levels are built up to a sufficient level, because it still remains in the system. 1/3 of it remains in the system for a couple of weeks. So you have to kind of gradually ramp that up. Early signs and symptoms of an issue with lithium might include nausea, vomiting, headache, hand tremors, excessive thirst, and slurred speech. As that toxicity begins to increase, we're going to start to see more neurological symptoms, and those will begin to show up as some ataxia, maybe some muscle weakness, incoordination, blurred vision, maybe even hyperflexia. The patient may eventually experience a seizure and become comatose, if this toxicity gets much worse. So sometimes the patients don't realize what's causing this. They're new to taking lithium. They start experiencing some of these symptoms, and they think, well, they need to make sure they take their medication regularly. And the problem is the lithium dose is too strong. They continue to take it 2 or 3 days into these symptoms starting up and it begins to reach toxic levels. So establish and maintain an airway with these patients. High flow supplemental oxygen is going to be helpful. Get an IV. If the patient experiences hypotension, of course, we're going to deal with that with serial boluses of normal saline. Maintain continuous EKG monitoring, and then, of course, transport that patient to an appropriate facility that can, manage their needs. Non-prescription pain medications, these are readily available as over-the-counter medications. So a lot of what we see here are the non-steroidal anti-inflammatory drugs, or the NSAIDs. These are rapidly absorbed from the GI tract and are eliminated from the body in urine, both urine and feces. The half-lives of these NSAIDs can vary widely depending on the type of NSAID that it is, and they're not all the same. It's usually 2 to 4 hours for ibuprofen and maybe up to 50 hours for some of the more longer-acting agents. Most issues arise from long-term use, including GI bleeding, kidney dysfunction, and acute ingestion and overdoses are really, really rare with NSAIDs. Many NSAID overdoses will remain asymptomatic. Very large doses are typically required before any signs and symptoms of toxicity begin to manifest. At toxic levels, signs and symptoms may include nausea, vomiting, and abdominal pain. Of course, our focus on these is going to be mostly generally supportive. Maintain a good airway, keep an eye on that. Administer high flow O2 as needed, get an IV. Fluid boluses if the patient is hypertensive. Watch for seizures and treat those with benzodiazepines. And of course, transport to an appropriate facility. And a unique adverse effect is aseptic meningitis. This is when the patient may present with a stiff neck, headache, and fever, giving you kind of those meningitis signs. But discontinuing the medication usually resolves the issue. Patients should be evaluated at the hospital to rule out whether there's another cause of it. Acetaminophen. This is another very well tolerated medication that has few side effects, is one of the best selling analgesics in the United States, and is often involved in toxic exposures because it's so readily available. Sometimes people will take this in a suicide attempt. Of course, lack of awareness that it is an ingredient in many other prescriptions or other preparations can lead to unintentional overdoses as well. So sometimes this is included in cough medicines and those kinds of things. So somebody they're fighting a cold or the flu and they take cough medicine and then they take acetaminophen on top of this. That's when we might start to see a toxic exposure come into play that is completely unintentional. So acetaminophen is rapidly absorbed from the GI tract. And of course, signs and symptoms for an acetaminophen overdose or acetaminophen toxic exposure is going to happen in a few distinct stages. And you can see kind of how those stages play out on the right-hand side. Hours to days is how long it's going to take for those things to play out. Acetaminophen is not something that somebody's going to recover from relatively quickly. Will take some time for that to pass through the system. So when you're managing these patients, make an attempt to accurately estimate the time of ingestion and try to determine the amount that they had taken. There is an antidote for it, and it's acetylestacine. It should ideally be administered within the first 8 hours after ingestion. It is given based on lab tests and is not a field intervention that we're going to be able to use in the pre-hospital setting. Establish and maintain an airway, get vascular access. For recent ingestions, we might be able to act, if it's relatively close to the ingestion time, go ahead and give activated charcoal after reaching out to medical control or poison control. So that may be a very viable option there. And of course, transport the patient to the hospital for further evaluation and treatment. Okay, so let's talk a little bit about some metals and metalloids. We don't always think about how toxic some metals are. but they can be extremely toxic, and exposure is typically rare, but exposure to these can have long-term and devastating effects. With asymptomatic patients or those with vague, non-specific symptoms, it can be really challenging to diagnose what's going on with them, and it may take a long time to get them diagnosed. But continuing, this is part of what contributes to the morbidity and mortality of these patients, is because it's so difficult to diagnose and so difficult to kind of pinpoint where that exposure is coming from. So when we talk about iron, only a small amount of iron is actually needed for a healthy diet. Many multivitamins contain irons. So an average 70 kilo adult, the body's iron supply is approximately 4 grams, with about 65% of that found in hemoglobin. Excessive iron in the body can accelerate the formation of oxygen-free radicals, leading to metabolic acidosis. It may also impact the coagulation cascade and the liver, resulting in significant coagulopathy. The toxic effects of exposure is going to depend on the amount of elemental iron ingested. Mild to moderate toxicity usually occurs with as little as 20 to 60 milligrams per kilogram, and severe, potentially lethal toxicity can occur with doses over 60 milligrams per kilogram. And oftentimes where this will happen, where we'll see this, unfortunately, is in children, where they get a hold of the Flintstones vitamins and they eat all of the vitamins or something like that, and they wind up with a toxic level of iron, as well as other things that can reach toxic levels that those vitamins contain. Symptoms of iron poisoning typically manifest in about 6 hours. Early stages are going to include like vomiting, diarrhea, abdominal pain, hematemesis, tachycardia, hypotension, and an altered mental status. These patients often present with metabolic acidosis and may become tachypnic as the body attempts to correct the pH by increasing the carbon dioxide elimination. So we would expect their respiratory rate to increase because they're trying to blow off excess CO2 in order to help correct the pH. A patient in later stages will present with profound shock, seizures, hyperthermia, liver failure, and coagulopathy. Of course, with these patients, we need to pay close attention to the ABCs and transport the patient promptly to a hospital for further evaluation and lab studies. There's not much we're going to be able to do in the field. Activated charcoal does not absorb iron, so it's useless in the treatment of someone who's recently ingested iron. So it's not going to work for that. It's going to more or less be probably some kind of a lavage, through a gastric tube. Arsenic is another heavy metal. It's involved in about 8% of heavy metal poisonings, and it's used in various industries, making it a common source of unintentional exposures. This is not something that somebody goes out and just readily finds. Intentional exposures can occur, and these are usually homicide or suicide cases, but it's typically kind of hard for someone to get their hands on enough arsenic to make a difference with that. Of course, it can enter the body through ingestion, inhalation, absorption, or even an open wound, and it's eliminated through the kidneys, is how the body will rid itself of it. Clinical presentation depends on the type of arsenic, the amount, the concentration, and the rate of absorption and elimination. So the route's going to make a big difference as well with that too. Symptoms generally appear within 30 minutes to several hours, and that's going to include things like severe abdominal pain, explosive diarrhea, a metallic taste in the mouth, dysphagia, general malaise, weakness, hypotension, pulmonary edema, rhabdomyolysis, metabolic acidosis, renal failure. We might expect to see some EKG changes and dysrhythmias with that, such as non-specific ST segment and T wave changes. Might even see some QT prolongation and ventricular tachycardia, as well as, in the more serious cases, all the way up to seeing torsades. So we can see a lot of things with that. This treatment for these patients requires a very aggressive intervention. So we need to establish an IV, high flow to get an IV access, and administer sequential boluses of saline to correct hypotension, and vasopressors or dobutamine may be needed in order to help get and maintain a blood pressure. Watch the EKG closely. Follow those ACLS algorithms when you come across for those dysrhythmias. And these patients are going to need a rapid transport to a facility, to an emergency room to get that arsenic taken care of. Poisonous mushrooms. The groups most likely to suffer from mushroom ingestion poisoning include wild mushroom pickers, someone that really doesn't know what mushrooms are what, and they pick the wrong mushroom, or they accidentally get a wrong mushroom mixed in with the right ones. Of course, individuals seeking the hallucinogenic mushrooms, or those attempting suicide or homicide. Of course, then we have young children that accidentally consume them. Ingestion typically results in limited or no toxic effects, but a variety of factors will determine whether a mushroom ingestion will produce toxic effects, such as the age of the mushroom, the season in which the mushroom was gathered, the amount ingested, how it was prepared. And of course, those toxic effects are going to range from mild gastrointestinal signs and symptoms to severe, potentially lethal cytotoxic effects. It's all going to depend on the mushroom and how mature and toxic that mushroom is. So there's a lot of factors that are going to come into play. So in the United States, many deaths are associated with a very particular species of mushroom. The timing of symptom onset can help predict the potential severity of the poisoning. If symptoms appear within approximately 2 hours, the event is most likely non-life-threatening. If the symptom onset occurs 6 hours or later, there's a significantly higher likelihood that the event will be fatal. So early signs and symptoms is better than late signs and symptoms. Common patient complaints are going to include symptoms like abdominal pain, diarrhea, vomiting, GI stuff, headache, and then ultimately it'll lead to multiple organ failure. So what we're going to do to take care of these patients is establish and maintain a good airway, get vascular access, administer fluids as needed to correct hypotension, and reach out to poison control and medical control in order to kind of come up and develop a treatment plan. Ideally, if you can identify the mushroom, if there's any parts of it left or anything like that, you might gather those, and put them in a container so that nobody else gets exposed to them, but bring them with you to the hospital, or maybe you can send images of those to poison control so they can help to be identified. Transport the patient to an appropriate facility for further treatment. Food poisoning, this is our last topic. We just got 2 or 3 slides, we're almost there, home stretch. So when 2 or more individuals present with similar symptoms at the same time at a particular location, consider that food poisoning or carbon monoxide poisoning could be to blame. You may be required to evaluate patients who are concerned after being informed of a particular food recall as well. Maybe they've consumed a food and now they've heard about a recall and they're worried that they're going to get sick. So sometimes this happens as well. But whenever we encounter a couple of people that are sick after eating at the same place, we should start to have a little higher index of suspicion of what it might be. So 3 toxins are commonly associated with food-related deaths, and that's salmonella, listeria, and toxoplasma. So these are the 3 ones that we mainly see. Salmonella is one of the highest ones that we typically see. Poisoning from botulinum toxin typically results from improper food storage or canning practices. The important thing to realize about botulinum is cooking does not eliminate those toxins that are present in there from poor food storage or canning practices. So it's important to realize that. Whereas with some of the others, it does actually, cooking does kill salmonella. The onset of signs and symptoms can vary from several hours to days, even weeks. GI complaints are the most common symptoms that we typically see with this, However, realize that respiratory distress and or respiratory arrest may occur with some of these exposures. Manage the patient's airway and provide respiratory support with supplemental oxygen as needed, and be aware and be wary of any, impending respiratory issues that may arise. Establish vascular access and treat hypotension due to fluid loss with fluid boluses of normal saline. Consider administering antiemetics according to your local protocol for those patients that are experiencing nausea and vomiting. And then, of course, consider administering diphenhydramine per local protocol for that facial flushing or, those types of issues that they may have. And, of course, transport the patient to an appropriate facility. All right, so we've talked about a lot of different toxins. And while it's important that you're familiar with these toxins, it's really going to be difficult for you to understand every one of them intimately. So what I hope you come away from with this is we can kind of group and categorize these, based upon, the toxic effects that they have, because the treatments are going to be essentially the same. We don't have to remember the treatment for each individual one. We can group them together and remember the treatments that way. So hopefully you're able to do that, and be able to develop treatment plans when you come across these. And of course, you should be familiar with those things that are common to your area, or if there's an outbreak of something. So, all right, we'll see you guys back at chapter 29.